Hello, my name is Kirsten Kuhn and I am a psychiatric nurse practitioner in the San Diego area. I currently practice at Mindbloom La Jolla and am opening up my own private practice in the Mission Valley area starting July 1st. I apologize for not being able to be there in person. Due to a family emergency, I unfortunately find myself traveling to Los Angeles and I can't be there. But it's still very, very, very important to me to speak with you and help bring recognition to World Schizophrenia Day. Most importantly, I want to celebrate for the first time in decades, we are beginning to use new medication treatments for schizophrenia, which are quite frankly better and have way fewer side effects. One of my greatest heartaches as a mental health provider is when a patient in their late teens, 20s, early 30s is diagnosed with schizophrenia. Why? Because it's not their fault. And I know that this diagnosis is going to profoundly impact them, likely for the rest of their lives. Schizophrenia is a genetic disease, and most of the time it just happens. Schizophrenia runs in my genetics as well. My grandmother had schizophrenia, which is likely one of the reasons why I am so passionate in helping patients that have psychotic disorders that they can live the best life ever. I have patients right now that feel that they were robbed of a normal life, and it's just heartbreaking to me because I want them to have jobs. I want them to be able to financially support themselves. I want them to be able to have families and grow with their families if that's what they want. And they can't. And it's not their fault. Schizophrenia causes positive symptoms of hallucinations, delusions, psychotic thoughts, and also can cause negative symptoms like poor motivation, isolating, apathy, where people don't really care about life, or even catatonia, which can sometimes lead to people to completely stop eating, drinking, or even talking. When positive or negative symptoms are really, really bad, my patients often end up in the hospital. Having worked in inpatient psychiatry, I've seen firsthand how helpful hospitalizations can be, and they really can be, but also having to go into the hospital is a pretty demoralizing experience, even in the best of circumstances with the best doctors. We used to think, as providers, that the primary cause of schizophrenia was abnormal dopamine signaling in the brain. Essentially, when dopamine is too high in certain areas of the brain, the patient experiences positive symptoms of schizophrenia, and when dopamine is too low in other areas, the patient experiences negative symptoms. The only medication treatment for schizophrenia for years has been a medication class called atypical antipsychotics. They almost all act by blocking dopamine D2 receptors, though some are different than others. Problem number one with using atypical antipsychotics for many people is that they sometimes work to lower dopamine levels for positive symptoms, the hallucinations, the delusions, the psychosis, but they don't really help with the negative symptoms, the poor motivation, the isolating, the apathy. Problem number two is that atypical antipsychotics have a lot of side effects, like weight gain, that can lead to heart disease or even diabetes, or tardive dyskinesia, which can lead to abnormal movements that don't always go away when the medication is taken away. So for many years, we in Western cultures have really only had this one tool to treat schizophrenia, and it has a lot of side effects. It turns out that we as providers have since come around to realize that there may be additional theories about what causes schizophrenia. There are now theories that perhaps schizophrenia is caused by problems with the glutamatergic system, or problems with other neurotransmitters like acetylcholine or GABA. We still believe that dopamine dysregulation plays a central role, but we are coming around to other factors playing a part in this. So, the next question is, other than antipsychotics, what newer options are out there? Well, there is a new medication called Cobenfy. It was FDA approved last year in 2024. It's a really exciting medication. What makes Cobenfy different than antipsychotics? Well, Cobenfy changes the message that neurons send to each other when communicating before the cells even send it, versus antipsychotic, which have to try to lower dopamine levels after a message is already sent and after dopamine levels are already high. Cobenfy takes care of the problem before the message is sent, which is revolutionary. How does it do this? Cobenfy contains xanomeline, which, in a roundabout way, reduces dopamine outflow before the message is sent. Xanomeline is naturally derived from a substance called arecoline, which is found in betel nut. Yes, it's a nut. Betel nut has been chewed for the last 5,000 years in Asian and Pacific countries as a treatment for psychosis. It's even been estimated that 10 to 20% of the world's population currently uses some form of betel nut, either for its psychoactive properties, which are not found in Cobenfy but in the nut itself, or to treat psychosis. So the pretty obvious question I get from patients when talking about Cobenfy is, well, why wouldn't I just chew a betel nut instead of taking medication? I don't really like taking medications anyway. Well, because betel nut unfortunately has cholinergic properties, which cause intense vomiting, GI distress, and nausea. In fact, there were some clinical trials in the 1950s and 60s to use arecoline, the substance in betel nut, for the treatment of schizophrenia, but the side effects, the nausea, the GI distress, the vomiting, were so bad that the studies failed. That's one of the reasons Western medicine instead adopted using atypical antipsychotics as a primary method to treat psychosis. The nausea and vomiting problem was reduced in Cobenfy when a product called trospium chloride was added, which tries to take care of the nausea, the vomiting, and the GI distress. So this is what makes Cobenfy different from other forms of the medication that failed clinical trials in the 20th century. Still, when talking about Cobenfy, GI distress is the primary side effect of this medication. This is why we recommend that Cobenfy is taken 1 hour before or 2 hours after a meal. And it's important to know that even if you do get this, the nausea, the vomiting, the diarrhea, it generally gets better with time, and with time that you spend taking the Cobenfy. But if this still doesn't get better, we will often supplement Cobenfy with other medications to try to help make it more tolerable, because it is a really great medication. Where I find as a prescriber that Cobenfy gets complicated is when a patient is currently on clozapine and wants to switch over to Cobenfy, which makes perfect sense. One of the biggest problems we worry about is constipation due to the constipating effect of clozapine and also the constipating effect of trospium chloride. The constipation can be so bad that the patient can be then hospitalized or even need surgery for a condition called paralytic ileus. Paralytic ileus is essentially an intestinal blockage caused by poop that doesn't move but through the intestines because the intestines are paralyzed. Clinical trials are currently underway about how to safely move patients from Clozaril to Cobenfy. Providers are starting to do it, but there really isn't a formal guide as of right now, so May 2025, about how to do it. So if you do want to make the switch, I would recommend that you make sure that it is done with a provider who's done it before. And I would also recommend using psyllium husk powder, i.e. Metamucil, daily in order to try to prevent constipation when using these two medications together. So how do I take Cobenfy? Cobenfy is taken twice a day, which yes is inconvenient, but it is a necessity. You take it at least 1 hour before or 2 hours after eating in order to try to mitigate some of the GI distress. The manufacturer recommends starting Cobenfy by taking 50 milligrams by 20 milligrams twice a day for at least 2 days, and then increasing to 100 milligrams by 20 milligrams twice a day. The dose can then be increased, if needed, to 150 by 20 milligrams twice a day, if needed. In clinical practice, I found that most patients do better in terms of GI distress when you keep them on the 50 by 20 milligrams for at least a week or two before increasing the dose again. Cobenfy is not recommended for patients who already have urinary tract retention issues, like men with BPH or women who can't empty their bladders completely. We need to be really careful when using Cobenfy in older patients because unfortunately these problems seem to come with age. We don't want to use Cobenfy in patients that have moderate to severe liver problems. We don't want to use Cobenfy with patients that have a history of gastric retention or the stomach that can't empty, if the patient has untreated narrow angle glaucoma, or if there's any allergy to trospium chloride. I hope you can tell, but I'm really, really, really excited about Cobenfy. I've seen patients getting their lives back, running, traveling internationally, holding down stable jobs, more involved with family and friends since making the switch from antipsychotics to Cobenfy. And what is most exciting to me is that this is just the tip of the iceberg on how we treat schizophrenia now and in the future. We won't have to deal with the same problems we deal with now with antipsychotics. finally, I just want to let you know, all of you, how incredibly proud I am of you for showing up today and continuing to grow and learn. Knowledge is power, and I hope that you leave today optimistic, knowing that life is only going to get better for you with technology in the coming years in terms of how we manage schizophrenia with medications. Thank you so much for your time, and I hope you all have a wonderful day.